Becky Ezel, and I am filming my video for my final project. I'm going to show you how the world of PICC nursing has changed based upon the informatics that are now available to us, as well as the new technology with the Sherlock machine that helps us find the best placement for a PICC line, the safest placement, while we're chasing zero here in the hospital, making sure that we avoid starting any central line infections. I have two nurses joining me who have experienced PICC lines for years. My manager, Susan Rhodes, is here now. I was going to ask her a few questions about how the informatics has changed. And so she has some experience with before computers became a part of this role. And about 10 years ago it was that informatics hit the medical world. So I'm going to turn my back to you while I talk to Susan. Susan, can you tell us, how did you receive notification that a PICC line was needed in a patient when you first started inserting PICC lines?
Phone call.
A phone call from the doctor?
From the nurse.
From the nurse. Mm-hmm. And did you have to follow the phone call to the doctor? And how did you verify that it was safe for that patient to receive a PICC line?
Well, believe it or not, back then they ordered a PICC line. We went upstairs and did it.
Without any investigation?
Without any investigation.
So
all we made sure is that the patient didn't have a dialysis shunt or graft in that arm. Okay. And that was about it. And we didn't measure the vein size. We didn't investigate anything.
So all these safety factors that we have in place now, based upon the new technology and the informatics, were not in effect at that time at all.
At all. The doctors we did it.
Would you say that it has improved the safety to the patient? And
Absolutely. Evidence-based practice has changed a lot of our practices. And with the use of informatics, it has saved a lot of time with the nurses to get up to the bedside a lot quicker, because we're able to investigate a lot off of the computer system now because of the electronic medical record.
Mm-hmm. Okay. So you probably didn't have to investigate in the chart, even the paper chart back then, about whether or not they'd had a previous PICC line. Mm-hmm. You didn't have to investigate their old paper medical records that was stored in the basement. You didn't have this access to the computer where you can do a single click and find all that information.
A lot of information, as I say, the only thing we really looked at is if the patient had any kind of renal significant changes with their creatinine. And if that was the case, then we would look to see if they had a renal disease process that was acute or chronic. And at that time, we would call the urologist, or the nephrologist, to see if it was okay for us to place the line. That was the only contraindication of placing a PICC line back then. Wow.
How did you document your insertion, and where did you find your orders for the insertion?
Well, the orders was in the chart. So we would paper chart. We would just write, they would say orders, insert PICC line. And then we would have this sheet of paper that was like fill in the blank, and we would put in the length of the catheter, which arm we placed at the lot number.
And that's it?
That's it.
Do you think that it was easy for a nurse, once that chart was thinned, because it got so thick and sent to medical records, was it easy for the nurse or the team to retrieve that information?
It was not easy to retrieve it. So a workaround that we put in place was we had a sheet of paper that we kept in the department that every PICC we placed would write the length of the catheter and the lot number. So if it did come back on us eventually, what we would do was we would go through these sheets of paper, find the patient's name, and they would call from a nursing home or wherever and say how long is the catheter, and we'd be able to locate it at that place.
Would you say that's pretty much equal to what we use in our informatic world of Excel now?
It pretty much is, the one that we're using now for the SharePoint site, because it is a lot quicker for us. Even if you can, if they call, we can look at the patient's medical record, but many times it's a lot easier for me as a manager, in order to try to get all the data as to how many catheters we placed on the lot numbers. It's easier for me to go into, say, your chart and find the numbers. So.
Wow, that's interesting how much it has changed. Okay. Thank you so much, Susan, for that history on PICC line placement and how we used to do it in the paper world. And now Angie's going to demonstrate for us, and if you need to go, Susan, please do. Thank you so much. We're going to demonstrate now with Angie, and she's going to show us on our PICC line insertion how we measure the diameter of a vessel with our new machine called Sherlock. We have put into the Sherlock our date of birth, medical record number, and patient name, so that this data will directly flow into the patient's chart as a part of our informatics success with the Sherlock. She's going to show us how she measures the vessel with the machine, as well as how to insert and realize that the machine has successfully placed the wire or the PICC catheter into the patient's chest. So Angie, please.
Hello. First thing I'm going to demonstrate for you all is how we now identify where a vessel is that's appropriate for PICC placement. And we use our ultrasound technology to do this. This used to be something that physicians did. Nurses have now been approved to use this technology. The ultrasound machine is extremely effective to identifying vessels. This is what a vessel would look like on ultrasound. We can change our range for our depth of vessel to show how closely we can see it. We can use this machine to measure our vessel. We would freeze the picture. Oh, not that one. Let's try this one. Pardon me. We can freeze the image. Then once the image is frozen, we can use the screen to do a measurement of the vessel size. This safely tells us what size vessel or catheter can be placed in this vessel to minimize risks such as a blood clot. Once that is identified and we take measurements, we prep the patient. Sterilely, we would access this vessel.
And this new technology with the ultrasound guided allows her to visualize as the needle actually enters into the vein. And there you are. So she is actually...
That bright white dot is the needle going into the vein there.
So once your needle is in place, then Angie would thread a wire through that needle that has echogenicity capacity, which means it will illuminate on our machine above, which I'll show you in just a moment, that will allow us to visualize the fact that the wire is dropping around the patient's chest into the larger vein just above the SVC. So I'm going to turn that.
Forgive us, our machine decided to cut off on us just a minute ago, and we may have to get this to...
What you'll be looking for is a drop from here. You'll see the wand come and drop down towards the patient's heart. That verifies to us with the informatics that we are successfully in the right place. And there's the drop. Wonderful.
Now we'll go to just above the level of the heart in the superior vena cava. And that will be appropriate placement for the PICC line, verified by this machine, which saves the patient needing to get a chest x-ray and exposure to radiation to verify placement.
And once it's in, Angie would hit print for us. The machine will print out a reading of the EKG showing us that it is successfully placed. This becomes populated with the patient's medical record number, date of birth, and name. And at that point, we would be able to put that in the chart so that it's a direct flow so that the patient's validation, and there's our paperwork showing that it is a direct flow. Can you turn it down just a little bit so I can see it? I don't know if you can visualize that or not. It'll probably look better once the video, there we go. And it's showing an EKG showing that we have successfully placed that PICC line in the patient's chest. So the patient will not require an x-ray, and so that's a huge improvement not only in the patient's safety but in the autonomy of that nurse, and the informatics session being able to locate and verify is a huge improvement for us as a team. I'm going to hit pause for a moment while I gather over at the computer and show you informatics about how we investigate the need and the safety of a PICC line placement for a patient. Thank you, Angie.